chromosome 9 and a previously unknown gene on chromosome 22, later termed PCR for breakpoint cluster region. So the PCR sequences are fused to the APL exon A2, and the breakpoints within the PCR gene localizes to one of three breakpoint cluster regions. The major breakpoint cluster region, as you can see here, result in the B210 fusion protein, which is found in the majority of CML patients, and almost 1/3, I would say, of patients with Philadelphia positive ALL. The minor breakpoint cluster region result in the B190 fusion protein, which is found in 2/3 of patients with Ph positive acute lymphoblastic leukemia and a minority of patients with CML. And the E19A2 fusion, which result in the B230 fusion protein, is found in some cases with chronic neutrophilic leukemia. So the pathophysiology of CML starts with the PCR APL signaling, which is critical and very important cardinal feature of CML pathophysiology. So the PCR APL is a continuously active tyrosine kinase, and this signaling has downstream signaling, and this activity and this signaling is directly related to the tyrosine kinase activity and other independent kinase activities. And there are other pathways that are active in CML, including recently described the HID-HOG pathway and BTN pathways, in addition to other pathways. So this is followed by the uncontrolled proliferation, and uncontrolled proliferation is was suggested initially when you do a marrow, for example, for a CML patient. The majority of the metaphases in the bone marrow are Ph positive, and this is also a cardinal feature of CML chronic phase. Discordant maturation, as the CML cells, CML progenitor cells, they have more differentiation and less self-renewal. And this imbalance between differentiation and self-renewal is called discordant maturation. Escape from apoptosis, and this has been shown in the CML progenitor cells are actually resistant to apoptosis. And lastly, the altered interaction with the cellular matrix, and it has been shown that the Ph positive cells are actually having less adhesion to the microenvironment, leading to expansion of the myeloid compartment in the bone marrow. This figures show you the molecular signaling, the complex molecular signaling of the PCR APL positive myeloid progenitor cells in the cytoplasm and the nucleus. So when the chronic phase CML transformed to blast phase CML, additional pathophysiologic mechanisms are needed. The continuity of the BCR APL expression or signaling is of paramount importance for the blast phase transformation. This is shown clearly in the pre-tyrosine kinase inhibitor era, that patient with continuous BCR APL activity inevitably progress to blast phase CML. However, both the presence of the tyrosine kinase inhibitor, the transformation to blast phase CML is actually rare. Arrest of differentiation is a characteristic feature of blast phase CML. Genomic instability is a well-known phenomena in blast phase transformation, and the BCR-APL signaling have shown to produce an oxidative oxygen species, which is actually damaging to the DNA and causes double-strand breaks. Additional chromosomal abnormalities are commonly found in patients with blast phase transformation. More than 80% of cases with blast phase CML have additional chromosomal abnormalities, most commonly in chromosome 8, double Philadelphia, and isochrome 17q. Inactivation of tumor suppressor gene are common in patients with blast phase CML. Almost 30% of patients with myeloid blast crisis have TP53 mutation, and patients with CML with lymphoid blast crisis, more than half of them, they have Icarus gene deletion. So it's known that patients with high-risk additional cytogenetic abnormalities in chronic phase CML, they have inferior outcomes. As shown in this paper, patients with high-risk additional cytogenetic abnormalities, they have lower survival probabilities. These high-risk cytogenetic abnormalities, including abnormality of chromosome 8, double Philadelphia, and isochrome 17q. Another paper showing that high-risk additional cytogenetic and chromosomal abnormalities are actually associated with poor outcome in patients with CML. And these high-risk additional cytogenetic abnormalities include trisomy 8, especially if trisomy 8 is in combination with other genetic abnormalities, double Philadelphia, complex karyotype, patient with chromosome 3, chromosome 7, isochrome 17, trisomy 19, and trisomy 22, they have inferior overall survival. It has also been shown that clonal chromosomal abnormalities in pH negative metaphases, like have been shown in this paper by the Inge Anderson group, patients with clonal chromosomal abnormality in pH negative metaphases that are non-Y deletion, they have lower event-free survival. Additionally, an important point to mention that kinase domain mutation that are usually acquired during treatment, first-line treatment, are associated with lower and worse outcome in patients with CML. So patients who acquire kinase domain mutation, they have lower cytogenetic responses, lower molecular responses, and lower progression-free survival, and higher risk of progression. Recently described somatic mutation have been shown to impact the outcomes of patients with chronic phase CML. Like in this paper from the German group, they studied the landscape of somatic mutation in 222 chronic phase CML patients at diagnosis by next generation sequencing. And they found that 24% of patients have somatic mutation, most commonly A6L1. And patients with A6L1 mutation, they had lower MMR at 12 months and at 18 months and 24 months, respectively. Additionally, patients with additional genetic abnormalities in addition to the semiotic mutation, mainly what's called the pH-associated rearrangement, which are complex rearrangement, including inversion, deletion, and additional transcript. These pH-associated rearrangement have shown in this paper from Australia to be So what they actually did, they combined the somatic mutation with this pH-associated abnormalities, and they found that patients with additional genetic abnormalities, they have lower survival and higher acquisition of kinase domain mutation and lower major molecular responses. And those patients with additional genetic abnormalities, including the somatic mutation and the pH-associated rearrangement, the molecular responses, deep molecular responses, MR4 and MR4.5, are actually halved. So in conclusion, I would like to say that PCR-APL promote glycogenesis through kinase-dependent and kinase-independent signaling pathways. The progression of CML from chronic phase to advanced phase is a complex process that's induced by continuous activity of the BCR-APL tyrosine kinase, differentiation arrest, DNA damage, additional cytogenetic abnormalities, and inactivation of tumor suppressor genes. Additional cytogenetic abnormalities, tyrosine kinase domain mutations, somatic gene mutation, and pH-associated genetic alterations at baseline or during therapy have a great impact on the outcomes of CML patients. By this, I conclude, and thank you all for listening.
Dr. Askar is there. Assalamu alaikum. I'm sorry for technical issues that I could not be with you initially. So I'd like to thank Dr. Askar if he was there introducing. And I think Dr. Salim, we can leave the questions to the end of after the second talks. Is that okay?
Yes, definitely.
Okay, so now it's my pleasure to introduce the second speaker, who is Prof. Valentin Garcia Gutierrez. He's a consultant hematologist from Madrid, Spain. He has extensive clinical and research experience in hematology, myeloproliferatives, and including currently he's the president of Spanish CML group. Dr. Valentin will his talk will be about the current CML management practice and guidelines updates. So, Prof, floor is yours.
Thank you very much. It's really a pleasure and an honor to be involved in this meeting. So thank you very much for this kind invitation. I really hope that for the next time I will join you in person. So please, if you don't mind, confirm me when you see my presentation in full screen.
Yeah, it's there.
Okay. So what I will try to do during the next 20 minutes is to show you what are the current CML recommendations for the treatment of CML patient. And for that, this will include how we manage the first line patient, the first step that we have to do after we perform a diagnosis of CML patient. Then how we should face an important problem at this moment for our patient, and that is that an important proportion of patients will not respond well to the first line treatment. And I will give you some information regarding what are new treatment options that we are starting to have available in the worldwide. At this moment, we have up to 6 TKIs or 5 TKIs regarding where you practice to treat our CML patient. Some of these TKIs, the so-called imatinib and second-generation TKIs, are approved in the first-line setting, and for the second line and later line, we have available also second-generation TKI, but also ponatinib, and in many countries, we already have available asciminib. So we have quite a number of treatment option that we can use in quite same categories of patients. So when we have different treatment options, it's important that we are familiar with all the treatment, with the guidelines and recommendations in order to try to prescribe the best treatment option for each patient. And this is what is really something really good that we commonly call to personalize our treatment option for each patient, not only regarding what we can expect for all these drugs in terms of efficacy, but also to diminish the possible of adverse events. And this is really relevant because, as you are aware, the majority of our patients will need to be on treatment forever, indefinitely. And this means that we need to try to avoid the potential of side effects in order to improve the quality of life of our patient, because we know that the current prognostic of our CML patient at this moment is close to the overall population. So it's important that we also focus on the quality of life of our patient. So these are data from the second generation TKIs and from imatinib from prospective clinical trial that nilotinib, dasatinib, and bosutinib obtained the indication with. And the first lecture that we can do with this approach is that yes, second generation TKIs seem to be a better treatment option for those patients in the first line, but we have to also to focus that many patients do really well on imatinib, and the probability of obtaining optimal responses are around 50 to 70%. And in a scenario now where imatinib is generic, so what we should do is try to identify those patients that are in risk of not achieving optimal responses with imatinib in order to prescribe only those patients the best treatment option, as is second generation TKI. So at this moment we have available in the first line setting imatinib for second generation TKI, and the question that we have to make is how we can identify those patients that may benefit from the use of second generation TKI in frontline. If we take a look to the recommendation from the American guideline, the NCCN guideline, but also the European Leukemia recommendation, we can see that they give us some information. They do not really tell us the group of patients that should be treated with second generation TKI, but they give us some information regarding what kind of patient at the moment of baseline should be considered as a warning. So that we have to be worried about this patient and probably offer them the best treatment option, the most efficacious one, which is second generation TKIs. And they tell us about the high risk regarding the prognostic model that I'm going to show you next slide, or as we've seen in previous presentation, those patients that present at the moment of diagnosis cytogenetic alterations. So regarding the prognostic risk model, we can see how by using the most useful one, which is the so-called index, we can easily identify those patients that are in risk of not achieving an optimal responses. So this is information from the NestMD study that compare nilotinib against imatinib, and we can see how for those patients classified as low risk, our patients are going to do well, and no matter what treatment we offer them, probability of obtaining optimal responses are quite similar, either if they start with nilotinib or imatinib. However, if we take a look to those patients classified in the intermediate risk, the probability of optimal responses maintain quite high, around 90% for those patients treated with nilotinib, but diminished to 70%. And take a look at what happened in those patients considered as a high risk. The probability of failing to the first line imatinib is quite high. More than half of the patients will eventually fail to imatinib. And if they are treated with second generation TKIs, this high risk has no impact at all. So these are, for sure, those patients considered as high risk, but also probably those intermediate risk are the patients that could benefit from the use of second generation TKIs. This may also apply to those patients harboring the so-called complete other cytogenetic alteration. And I'm not going to go in depth with this data because it was very nice presented in the previous presentation. Probably at this moment we can do even better, and we have now information. It was recently showed in the latest presentation how also the presence of so-called somatic mutation associated to cancer we also may have an impact in the prognostic of our patient. And we have data from the Australian group, but also from the Italian group, that those patients harboring the so-called somatic mutation also may benefit from the use of second-generation TKIs compared to imatinib. Another factor that could be taken into consideration is the type of transcripts. As you know, around 19 to 95% of the patients are going to harbor the so-called transcript P210. There are two types of these different transcripts. It is true that it has been described some difference between these two transcripts, but they all we should consider as the same prognostic. However, there are around 2 to 3% of patients that may harbor what we commonly call a rare transcript. And this is important because these rare transcripts do have an impact in progression-free survival and also in overall survival, especially the one that is really very rare, the so-called P190, in which prognosis is diminished compared to progression-free survival and overall survival. And we also have data that this patient may benefit from the use of second-generation TKIs compared to imatinib. The last group that I would like to discuss with you is something that it has been recently described. For many years ago, we didn't see the impact of the so-called young patient. And at this moment, we do have information for how those so-called young patients, and that means an age under 30, have an prognostic, an impact in the prognostic. They have a worse prognostic, not only regarding to the probability of complete cytogenetic response and major molecular response, but also in progression-free survival and event-free survival. The reason for this is that why it took so long to be aware of the prognostic of the so-called young patient was because, as I previously showed you, the most used prognostic factor until now was the SOCAL. And the SOCAL had an important impact in the age of the patient. I'm very sure that all of you that have experience treating CML patients, it's really very, very rare that a young patient, even if the patient has high rate, a high number of blasts, splenomegaly, or even an important number of platelets, is really very rare that a young patient is going to classify as a high risk. And this is because the age plays an important role in this SOCAL index project. So this is why at this moment the prognostic factor that we're using are the UTOS long-term score, in which the age has no impact at all. So especially in the young patient, it's very important that we use this UTOS score instead the SOCAL in order to identify those young patients in which the prognostic may be disfavorable. So fortunately, an important proportion of patients are going to achieve what we commonly call an optimal response, which is that the patient achieves a major molecular response, the BCR-ABL level below 0.1%. But in addition, those patients that achieve what we call a deep molecular response, we can obtain something that is considered at this moment a new endpoint. And that endpoint is the possibility of treatment-free remission to discontinue treatment. And you can imagine the possibility of discontinued treatment is really very important for many patients. We can discuss this further on, but for an important proportion of patients, it's really very relevant to discontinue treatment if possible, not only to diminish the adverse events that they might be suffering and so to improve the quality of life, but also in the point of view of psychological, it's very relevant to stop treatment. And at this moment, we have performed an important number of clinical trials that showed us that treatment-free remission is feasible. And when we select the patient, is really those patients can discontinue the treatment. However, it's very important to know that in order to treatment discontinuation, the first step is that our patient need to achieve what we call a deep molecular response, major molecular response below 0.01. And it's important to consider that when we start treatment with second generation TKI, in this graphic, nilotinib compared to imatinib, the probability of achieving deep molecular response is double when we use second generation TKI and especially nilotinib. So if our goal is TFR, treatment-free remission, the possibilities are much higher by using also second generation TKIs. There are a few number of recommendations and guidelines in order to identify those patients that could be candidates for TFR strategies. And we can summarize that the patient needs to be always in a chronic phase. It does not apply for second line. Always in a chronic phase, and probably under treatment for a period of time to 6 to 8 years, and what we call in a deep molecular response for at least 2 years. When our patient fulfill all these criteria, this is possible to perform it not only in clinical trial but also in the real life setting. And this is a paper from the MD Anderson group showing how we can do even better and how important is time of treatment. When they took a look to the series on the MD Anderson and they classified the possibility of treatment discontinuation according the durability of deep molecular response previous to treatment discontinuation, we can see for those patients that were on deep molecular response for more than 6 years, the probability of TFR was over 90%, compared to only 70% in those patients with deep molecular response for less than 5 years. So the time on treatment and time on deep molecular response is very relevant. So for the first line, we could use this algorithm in which we need to know the risk of the patient regarding prognostic index, cytogenetic, transcripts, and probably in the next future the somatic mutation, the mutation associated to cancer, and the age. For those patients that are considered low risk, they are going to do fine with imatinib. There is not really a need to start treatment with second generation TKI. However, for those patients that are considered intermediate or high, we should take into consideration second generation TKI because it's probably the best treatment option. And if a patient is considered or classified as a low risk, if there is a special motivation on treatment-free remission, the second generation TKI strategy should be also considered, because as I previously showed you, the possibility of achieving deep molecular response is much higher. What about those patients that fail to the first line setting? Well, the first thing that we need to take into consideration is that this is quite frequent. The possibility of failure to whatever treatment that we start in the first line setting is quite high. Around 40% of the patients are going to discontinue treatment regarding lack of efficacy or intolerance. If we start patients with second generation TKI, dasatinib or nilotinib, it is most frequent that our patient will fail due to intolerance compared to resistance. On the other hand, if we start treatment on imatinib, it's more frequent that the patient will fail to treatment due to lack of efficacy compared to intolerance. The good news for those patients that fail to imatinib in the first line setting is that we have approved up to 3 different TKIs, dasatinib, nilotinib, and bosutinib. And the good news is there is not really, is not a big deal what treatment do we use, because the possibility of obtaining optimal response are quite similar among all these treatments. And this is not really also very relevant to discuss whether the patient really failed to intolerance or lack of efficacy, because the probability of achieving optimal response are quite similar among all different treatments. So if we have different treatment options in which the efficacy is quite similar, the question is clear. How do we use, or how we identify the best treatment option for our patient? And we need to focus in two different patterns. The first one is the patient comorbidities. We know that all TKIs are related to specific adverse events, and these adverse events are more frequent regarding patient comorbidities. For example, nilotinib has been considered, has been related in a more higher probabilities to cardiovascular risk, cardiovascular events, compared to dasatinib and bosutinib. This is why if patient has a very high risk of cardiovascular comorbidities, nilotinib should not be considered. In the same sense, for those patients that have pulmonary problems, dasatinib should not be considered as the best treatment option due to the probability of pleural effusion. And if our patients are suffering from liver problem or gastrointestinal problem, bosutinib should be avoided. It is also very important to take into consideration that we know how around 15 to 20% of the patients that will fail to imatinib of later lines are related to the mutation that confer resistance to a specific patient. And we need to perform mutation testing, if possible, by next generation sequencing strategy in order to identify what, in case that we identify one of these mutations, we make sure that we offer the best treatment option. I'm very sure that you're familiar that, for example, if a patient harbors the mutation T359, the only treatment option that are effective used to be ponatinib, and now we know that asciminib is also effective. The most important problem is what do we do if patients fail to second-generation TKI, especially in the second line. And this is also an important problem. We can see that once patients start in a second-generation TKI, the probability of treatment failure is as high as 50 to 70%. And we can see how the problem is quite similar regarding to lack of efficacy or intolerance. This is important because since in the last year, we focused too much in the resistant patient, but we can see how intolerant is an important problem, and probably even higher. It is more frequent that a patient fails due to intolerance than due to resistance. But it's important to take into consideration or to really identify what is the reason for treatment failure, because the treatment options that we should use are different regarding whether the patient are considered intolerant or resistant. And if that is important, we should have clear the definition. In order for resistance, it's really very easy to identify those patients that are resistant. The only thing that we have to perform are PCR in peripheral blood and to measure the BCR-ABL level. And we can see how at any time after 12 months of treatment, a BCR-ABL test above 1% should be considered as resistant, and therefore those patients should be candidates for later lines treatment. The definition of intolerance is not so easy, and we can see how it's quite not really objective or subjective definition. For many years ago, the definition for intolerance was to suffer an adverse event grade 3 or 4. At this moment that we have different treatment options, I'm very sure that all of you will agree that even if the adverse events are not severe, but are low, the so-called low grade, for example, grade 1 or grade 2, but they maintain on time and have an impact in the quality of life of the patient, we should offer a new treatment option in order to improve the quality of life. As I mentioned, it's important to define, to know the reason why our patient failed to treatment. And this is important because in case that the patient failed due to intolerance, as this is information from the Beyond study for bosutinib, we can see how probabilities for retreatment with another second generation TKI, the probability of obtaining optimal response are really high, close to 80%. On the other hand, if a patient failed due to resistance, the possibility of rescue of a patient with a that failed to a second generation TKI with another second generation TKI is not that high, and therefore that's the reason why we should change the line and offer a third generation or even fourth generation for this patient that failed due to resistance. We have information how for many years, the most effective drug was considered ponatinib. The possibility of achieving optimal response in patients with previous resistance to second generation TKI in the third line or the fourth line was as high as 60 to 70%, and probability of achieving even major molecular response was around 50%. So this was considered the most effective drug. But as you know, the main problem with ponatinib are the probability of suffering cardiovascular event. This is why the recommendation was to diminish the dose of ponatinib to 15 milligrams once patient achieved response. This is something that we have been performing for many years, but there was a lack of information in a prospective clinical trial. And this is why we conducted this OPTIC clinical trial in which patients with resistant definition to second generation TKIs were treated with 3 arms of ponatinib, 3 starting doses. Ponatinib 45 milligrams, ponatinib 30 milligrams, or ponatinib 15 milligrams. And in this study, it was mandatory to diminish the dose when patient achieved response. So we answered 2 important questions in the use of ponatinib. The first one is, what is the best starting dose? And we can see how the best starting dose is ponatinib 45 milligrams. The probability of achieving optimal response are higher when using 45 milligrams instead of 30 milligrams, but as it was expected, the main benefit is from those patients that are considered as high risk, the patient harboring the T315I mutation, those patients with a lack of complete hematological response at baseline, or those patients that were previously treated with 3 or more TKI. Those are the patients that benefit the most from the starting dose of ponatinib 45 milligrams, but in general, all the patients benefit from this dose. However, it's very important to highlight that by reducing the dose and better selecting the patient in order to the cardiovascular risk, we have diminished the probability of suffering arterial occlusive event. And we have diminished this possibility from around 25% from the OPTIC study to less than 7% when using the dose of 45 milligrams and then diminish to 15 milligrams. So it's important that we use this dose adjusted scheme when using ponatinib. And this is why until now the latest recommendation in the European Leukemia Net recommendation for resistant patients, the use of ponatinib. So the algorithm that we can use for those patients that are treated that fail to second generation TKIs is to evaluate the reason for treatment failure, to evaluate CML phase, if they are still in a chronic phase or advanced phase, the ratio, the mutational status, the adherence, the tolerabilities, and also the comorbidities. And it's very relevant, as I mentioned, to really distinguish whether the patient failed due to resistance or intolerant. Those patients that are resistant should be treated with ponatinib if possible, or if it's not possible due to cardiovascular risk, to alternative second generation TKI. If the patient failed to second generation TKI due to intolerance, they still have a chance to be treated with some other second generation TKI. Fortunately, recently we have approved in many countries a new treatment, which is asciminib. We are going to see in the next slide, and the possibility of having asciminib available has completely changed this algorithm, because now we know that asciminib should be considered even in both groups, in those patients that fail due to resistance and due to intolerance. So what is next in CML? Well, if the main problem that we have, as I mentioned, is the patient that failed to second generation TKI. And we know, as I mentioned, that this patient failed due to intolerance and due to resistance. Regarding to intolerance, we know why patients are intolerant to the TKIs that we are currently using. And the reason is because the TKIs that we are using are really effective in order to inhibit the BCR-ABL level, but the problem is that these TKIs do not only inhibit BCR-ABL, but also inhibit some other kinases. And the inhibition of these kinases are directly responsible for the adverse events that we are commonly seeing with the TKIs that we are using. Regarding to resistance, it is not so well known the mechanism that confer resistance, but it's important the mutational status, as the president mentioned, and we now know that the more powerful that the drug is inhibiting BCR-ABL level, the greater benefits. And this is not always so easy, and it's quite frequent that our patient is not only intolerant or resistant, are both intolerant or resistant. So in this patient, we are very fortunate to have new treatment option, as is asciminib. Asciminib is a new treatment, is a novel TKI with a novel mechanism of action. It's very important to highlight that this drug, compared to the rest of TKIs, do not work by binding to the ATP binding site. They bind in the myristoyl site, and this is very important because it has two relevant specific consideration. The first one is that due that this drug works with a different mechanism, it can be combined with conventional TKIs, and this is very important because especially in those patients harboring mutation, because our patient may have one mutation but also different mutation, and this mutation may confer resistance to conventional TKI but also to asciminib, and to have a drug that can be combined to conventional TKIs may be also useful. What is really relevant is what happened when we see how selective this drug is. These are phosphorylation studies, very similar to the ones that I previously showed you for the previous TKI, and we can see how asciminib is really very specific for the inhibition of BCR-ABL and does not inhibit any other kinases. And this is the reason why this drug is so well tolerated. The drug was evaluated in a successful phase 1 study, was successful in terms of efficacy and tolerability, and this is the reason why Novartis conducted a phase 3 study in which asciminib was compared to bosutinib in patients that had previously failed to second generation TKI. We can see how the primary endpoint, that was the probability of major molecular response, was double with asciminib compared to bosutinib, and some other endpoint as complete cytogenetic response and the molecular response were also superior for asciminib. And thanks to the specific inhibition that I previously showed you, we can see how this drug is really very well tolerated. The probability of adverse events are very infrequent with asciminib, and we can see how the probability of suffering adverse events are much higher with bosutinib. We also have experience with the compassionate use program that Novartis started in worldwide, and in our Spanish CML group, we have published different papers showing that the result in the so-called real-world studies are similar compared to clinical trial. And this information is not only in our Spanish CML group, there are some other groups in the Canadian, Russian, and Australia that have showed us how the asciminib in the worldwide experience is quite similar to the result obtained in clinical trial. So my conclusion are that it's important to keep in mind that there is a group of patients that may be around 30 to 40% of the patients that should be taken into consideration for the first line treatment because they should be considered as high risk patients. That TFR is a new treatment goal in our patient in CML, and when treating with second generation TKI, the probability of achieving this goal is superior. The importance of identifying the reason for treatment failure for those patients to second generation TKI, because the treatment option may differ regarding the patient are considered intolerant or resistant, and asciminib is a new treatment option at this moment for our CML patient that is available now in the third line, but we are performing clinical trial also in the second line and in the first line. And and I'm very sure that we are going to be talking about asciminib in CML in the next future for future indication. With that, I will conclude telling you again how excited I am about participating in this Congress, and thank you. I would like to thank all the members for our Spanish CML group that have participated in some studies that I showed you the results. And now I'm very happy to be open for discussion or question. Thank you very much for your attention.
Okay, thank you, Prof, for excellent presentation. We will have a few minutes for some question and answers. But before that, I would like again to thank SSBMT for organizing these webinars. And I would like to thank Novartis Oncology. See if there is any questions. I'm still waiting for a submission of questions from audience. But I could ask both of you, Dr. Salim and Prof, when would you consider to do like more evaluation, such as NGS for CML patients? At current time, is there any recommendation to do myeloid panel for these patients, like if they have, for example, additional chromosomal abnormalities or complex karyotype? And if you find any additional mutation analysis, what would be your recommendation? So I would like to hear from both of you.
Well, that's a very relevant question, and in this moment it's important to highlight that there is not a clear recommendation to perform this test in the clinical in our clinical practice. I mean, this is only in academic center for investigational information. There are no guidelines and no recommendations that recommend to perform a myeloid panel. However, I am aware that in many centers there is no really possibility to perform karyotype. Karyotype is really relevant because it tells us information regarding a high-risk patient. So possible in those patients in which karyotype is not available, to perform this kind of panel could give us some information. They are not going to give the same information that we can obtain with a karyotype, but they can give us some information in order to take treatment consideration, because in case that patient harbor some of these mutations, they could benefit from second generation TKI. That could be my advice regarding this topic.
Dr. Salim?
I think doing karyotyping is essential in the baseline. So you have to do karyotyping looking for additional cytogenetic abnormalities. And in those patients with additional cytogenetic abnormalities, they are high risk, and probably you should consider a second gen TKI upfront. Doing a molecular profile, there is no clear guidelines, as mentioned by Dr. Valentin. There is no clear guidelines for that. However, in the literature, it's almost 25 to 30% of patients, they have this mutation. So probably in the coming future, we may see some guidance to in which patient we should do them. And probably those patients with these additional genetic abnormalities, probably they may benefit from the use of a more potent second-gen TKI upfront.
Okay, we have another questions from Dr. Osman Binyam. With the availability of ponatinib and asciminib, should we still take all patients in blast crisis to allotransplant? Prof.
Yes, I mean, a patient that is in a blastic phase, even in case that a patient obtain an optimal response, we know how the probability of maintaining the response is really low, and we should use asciminib or ponatinib as a bridge therapy prior to transplants. It is different in case that we know that if a patient has been in a chronic phase without an optimal response, and a patient achieve an optimal response always in the chronic phase, those patients, there is no need to perform a transplant. But in case of accelerated phase, not at the diagnostic, but during the evolution or even black tissue phase, those patients clearly benefit from stem cell transplantation.
Okay, I have questions about subgroup or special group of patients we see in our young ladies who are planning for pregnancy. How would you approach a similar case scenario?
Yeah, it is regarding that is important. Regarding pregnancy, I know it's not the question, but I think it's also important to mention that in case of males, there is no need of discontinue of doing anything. On label, they say that, I mean, the TKI may be heterogenic, but we have enough information to say that in case of male, there is no need to treatment discontinuation or do anything. In case of a woman that have a pregnancy desire, is what we commonly perform is that we stop treatment as soon as the lady knows that she is pregnant, and we monitor. There are two different treatment options. One is to give interferon in order to maintain the previous response, but this is not really recommended by all the groups, and there are some group, and this is my case, that the only thing that we recommend is treatment is monitoring, because the possibility of losing complete hematological response is really very rare. And what we commonly do is we monitor viscerable, but also what is very important is the hematological response. And we do not consider to do anything if there is a molecular response, even if the patient lost the cytogenetic response. And we only consider treatment in case of losing a complete hematological response, which is very rare, as I mentioned. In that case, what we perform is that if it's in the last 3 months, we know how TKI, especially imatinib, is safe, and you can introduce imatinib. If the loss of complete hematological response is between the 1 month until the 6 months, you should consider the use of interferon, because the use of TKIs before the 6 months may be dangerous for the baby, and this is the approach that I recommend.
Thank you. So quickly, Prof, comments about asciminib if there is a CNS disease, and use of asciminib if patients develops TKI-induced cytopenias, because we are run of time. So if you can make a brief.
Yeah, absolutely. I mean, we have seen how asciminib diminished almost all adverse events, but not the thrombocytopenia. The thrombocytopenia is also quite frequent when patient treated with asciminib. What we recommend is that we start with imatinib full dose, and we have experience tapering the dose, and we know how diminishing the dose, even instead of giving 45 milligrams twice a day, we could give, if a patient achieves response, 40 milligrams once a day, and we have some experience that could help in order to treat those cytopenia. But cytopenias are also an important problem also for asciminib.
And for CNS disease?
For CNS disease, as far as I know, there is no experience. And what I will recommend was to perform intrathecal chemotherapy, and then that's a definition of blastic phase, and those patients should go to a stem cell transplantation.
Okay, so by this, I'd like to thank our speakers for their excellent presentations. I'd like to thank SSBMT for organizing this webinar and Novartis for sponsoring this educational activity, and hope to see you soon in the next webinar sponsored by SSBMT, which will be on November 1st, Reshaping Against CML. We will have Dr. Mohsen Al-Zahrani and Dr. Dennis Kim. So hope to see you, inshallah, at that time. And thank you again, and see you soon.
Thank you very much. It was really my pleasure. Thank you.
Thank you. Thank you.
Thank you.
Bye.
Bye-bye.